Good morning, Dr. Butler. Thank you for joining us for the ACC Fits on the Go, the Fellows in Training on the Go, and thank you for helping us out with this video.
Thank you for asking me.
All right, so the key question, let's start with the 30-day readmission part. So based on your talk, what do you think were the most important predictors of patients who would be readmitted within the 30 days period?
You know, it is a really, really complex issue for this readmission because unlike mortality, which is largely driven by medical factors, readmissions are driven by so many other issues that there's a whole bunch of clinical factors that are associated with the readmission, but not all the clinical factors that put you at high risk for readmission necessarily are also targets of therapy, right? So, I mean, just because it's a risk factor doesn't necessarily mean it's a target for therapy. Comorbidities, incredibly important. So tight control of comorbidities will reduce the risk. There are patient-related factors, there are psychological factors, there are insurance factors. So I think it is very complex. But what is also true is that no matter how complex it is, hospitalization for heart failure are incredibly costly and are associated for worse prognosis. So whether we need to work on the biologic side to understand biology and come up with interventions, or we need to work on quality of care side to have better care processes for transitions of care and post-discharge follow-up, we have no option but to do all those things.
Right. I think those are the key things coming up now. Many hospitals are following up on the post-discharge follow-up of the patient just to make sure that they are steady and they are taking their medications pretty well. So that will be a key thing in the future. Just not inpatient care, but extended care after they are discharged, just to make
That's
sure
a part of the value-based care, right? So I mean, in a way, as you start moving away from episodes of care to population management, this will be an integral part of how we take care of patients.
Right. And there were a few talks about rehabilitation after discharge. That was key thing as well. I know there's not like post when I see patients in the clinic, especially after CABG or after PCI, we recommend cardiac rehabilitation. That's not well seeped into like heart failure admissions and other stuff. So I think
this is very interesting what you're saying, right? Because the heart failure community had so many small studies and for the longest time believed that cardiac rehab is good for patients with heart failure, but the reason people gave that they are not doing it is because it wasn't paid for by insurance. And then we finally did this large study, HF Action. It showed that if you adhere to exercise regimen that you improve outcomes, and then CMS gave a code, and now it is a paid-for indication, and yet we don't do that. So there is a mindset issue that with vascular disease, CABG, PCI, we do send the patients, but this is a big lost opportunity. But I do also know that there's a lot of things going on in the external environment to increase the rate of rehabilitation referral. So hopefully this will change. I think the needle will move on this one.
Right. And I think the key would be to see which patients are at higher risk for coming back, and then try to more focus on them just to make sure.
So that's another very insightful point that you just made, because we just don't have, no matter how rich a hospital you are or how poor a hospital you are, nobody has the resources to do everything for everybody. So we have to risk stratify and start targeting. And part of the reason why maybe the current interventions have not worked is that maybe we don't intervene as well as we should because we are stretched too thin, and then whatever the benefit is, it gets kind of diluted out by low-risk patient. So targeting the high-risk population rather than doing everything for everybody is the way to go.
Right.